All right, welcome back. So this week we're going to conclude our section of the class on the cardiovascular system. So we started out with blood, talked about the heart, and so now we're on to blood vessels. But of course, talking about the heart and talking about the blood, I touched on a lot of this information previously. So hopefully not a ton of this will be new, and it'll be pretty straightforward and relatively easy for you. So in terms of blood vessels, so the three major types that you can see there, so the primary two that we'll spend our time talking about are arteries and veins. So the thing to know is that arteries carry blood away from the heart and veins carry blood back toward the heart. Now in general, arteries carry oxygenated blood, or oxygen-rich blood to use the terminology that the textbook uses, and then veins carry deoxygenated blood, or oxygen-poor blood, again to use the same terminology. But of course that's not the case 100% of the time, because you've got the pulmonary arteries that are leaving the heart, right? So the pulmonary arteries are carrying blood away from the heart, but they're leaving the heart and headed toward the lungs, and so the pulmonary arteries actually carry deoxygenated blood, and then you got the pulmonary veins coming back from the lungs, and those carry oxygenated blood. So those are part of the pulmonary circulation. So in the pulmonary circulation, the oxygenated, deoxygenated roles are reversed. In the systemic circulation, so everything else, arteries carry oxygenated blood, veins carry deoxygenated blood. So for the most part, I will kind of use that as a shorthand, and unless I'm talking about the pulmonary circulation, I'll be specific about that. But in general, so in the systemic circulation, which is everything else, arteries oxygenated, veins deoxygenated. And then, so the arteries and veins just carry blood, they're conductance vessels. Capillaries is where gas exchange takes place, because remember what we're trying to do with the blood is to transport things, and the primary things that we're going to be transporting are oxygen and carbon dioxide. We're trying to deliver oxygen to the tissues so they can use that oxygen to make energy to fuel all the things that they have to do, whether it is running sodium-potassium pumps or fueling muscle contraction or a variety of other things that they do that take energy. They need oxygen ultimately to do it. And so we have to get that oxygen to those cells, and obviously we do that by transporting the oxygen bound to hemoglobin and in the blood. Now, where that oxygen moves from the blood into the tissues is in the capillaries. So that's when I say gas exchange, I'm meaning that oxygen is leaving the blood and moving into the tissues. And then carbon dioxide, CO2 there, goes the other direction. So carbon dioxide is manufactured or synthesized in the tissues, and then it moves from them into the bloodstream, and then we bring it back to the lungs, and then we breathe it out. So we get rid of that byproduct of the energy production process. So for now, the thing to know about capillaries is that gas exchange takes place there. So you might wonder, I suppose, why gas exchange doesn't take place in the arteries or veins, and the answer to that question is that the tissue around the arteries and veins is simply too thick. So both oxygen and carbon dioxide move with their pressure gradients. They diffuse, but they can't move very far. And so the more layers of tissue you have, for example, as you'll see here in a second, arteries and veins both typically have 3 layers of tissue. The more layers of tissue you have, oxygen simply can't diffuse that far. It can't move through that many cell layers. So we need really thin vessels, the capillaries, in order for gas exchange to take place. All right, so here's the basic mock-up of arteries versus veins. On anatomical diagrams, arteries are always red, at least on every one I've ever seen. Arteries are always red, and veins are always blue. And again, that's to symbolize that arteries are carrying oxygenated blood and veins are carrying deoxygenated blood. So it has that darker color, and veins kind of have that blue appearance. So in terms of the structure of each, so we're talking now about an artery. We'll get to veins in a minute, but you can see both on that drawing there. So here's your artery on the left side and your vein on the right side. So each of them is going to have 3 layers, and those layers are called tunics. So the innermost layer, or the deepest layer, if you will, is the tunica intima. And so the tunica intima is intimate with the blood, has an intimate relationship, if you will, with the blood. Sounded kind of seductive. Not meant to be that way, but it is in direct contact with the blood, as opposed to the other two. The tunica media and the tunica externa are not in direct contact with the blood. So the intima is the deepest layer. It is that endothelial tissue that we've talked about previously. So remember when we talked about different types of tissues. We talked about epithelial tissue, which is the covering and lining tissue, and we talked about endothelial tissue, or the endothelium, being a special kind of that. So the endothelium is epithelial tissue that lines the inside of blood vessels, and so that makes up the tunica intima. And so you can see the tunica intima here, and you can see endothelium. Now, in larger vessels, in addition to having that endothelium, there's also going to be a subendothelial layer that has a basement membrane and loose connective tissue. In really small vessels, you may see essentially just an endothelium. So in some of the smallest capillaries, it's basically just one cell layer thick, which again facilitates that gas exchange that takes place. One of the important things about the endothelium that we've touched on previously is that it has a really slick Teflon-like surface, so it keeps the blood cells, red blood cells, from sticking to it unless there's damage. And if there's damage to the endothelium, if it's cut or torn or something like that, then that breaks up that smooth surface, and we've talked previously about clotting and all the steps involved in that. So if there's a disruption of the endothelium, then that prompts platelets to stick to that area, that prompts white blood cells to migrate to the area, those kinds of things. But under normal circumstances, when the endothelium is intact, it's nice and slick and keeps things from sticking to the vessel walls. And then superficial to that, so the middle layer, is the tunica media. And so that is pictured here. So the tunica media is a layer of smooth muscle. So remember that with smooth muscle, that is an involuntary type of muscle. So it contracts because it's muscle, but we can't consciously control that. So that smooth muscle layer around arteries serves a couple functions. One is that it helps with the elasticity of the vessels, and you can see in addition to the actual smooth muscle layer, there's also an internal elastic membrane in larger vessels, and then an external elastic membrane. So that's a lot of those elastin fibers, which is why it has kind of that yellowish color there. So that smooth muscle layer then contributes to, again, the elastic quality of the vessel, allows the vessel to stretch and recoil. But in addition to that, it helps play a really important role in direction of blood flow. So if this particular tissue doesn't need blood flow at this time, we'll get a contraction of this smooth muscle in the tunica media, and when that closes, when that muscle contracts, it's going to close down the blood vessel. It's going to narrow it down, and so then that limits blood flow to that particular area. That smooth muscle is under control of the sympathetic nervous system. So we covered branches of the nervous system in 201, but to touch on it briefly, the sympathetic nervous system is it's part of the autonomic nervous system, which is encompasses both fight or flight and rest and digest. The autonomic nervous system are automatic muscle motor functions is probably a better way of saying that. Automatic motor functions. And so the sympathetic side of the autonomic nervous system is the fight or flight side. So if you're scared or if you're exercising, the sympathetic branch of the autonomic nervous system causes a vasoconstriction, causes this smooth muscle to constrict and close blood vessels down. So there's two terms on there, vasoconstriction and vasodilation. Vasoconstriction, as I just mentioned, is when this smooth muscle layer contracts, and that's going to narrow the blood vessel and decrease blood flow distal to that site. So any tissues beyond that point are going to see a reduction in blood flow. So vasoconstriction, blood vessel closes down. Vasodilation is when the blood vessel opens up. So what we get there with respect to the smooth muscle is that smooth muscle is going to relax, and that's going to increase blood flow. So the tunica media then, again, serves two important roles there, the elasticity of the vessel, but then also in direction of blood flow. And then the most superficial layer is the tunica externa, and as you can see from the diagram there, it's mostly collagen fibers. So it's going to play a really important role in blood vessel integrity, so kind of shoring up some of those deeper layers because of its extensive collagen network. And then in addition to that, that tunica externa also helps anchor the blood vessel to surrounding structures. So it helps keep it in place. So that's its job. Another term on there is the lumen. So a thing to know is that the lumen is just the inside of the blood vessel. So the hole here in this artery, that's the lumen, and then the hole in this vein here, that's the lumen of the vein. and we'll use the same terminology when we talk about the stomach and the intestines. So the lumen of anything is that the innermost part of it. It's the opening in the middle. All right, so on the arterial side, remember that the left ventricle, when it contracts, ejects blood out into the aorta. The aorta is an elastic artery, has a really thick layer of smooth muscle around it, and a lot of elastic fibers. So it is going to stretch and then recoil. And so when it recoils, when it returns back to its original or resting size, that helps propel blood along toward the tissues. So blood goes from the aorta, and then it moves into large arteries, and then eventually into arterioles. So we're moving from the aorta. So the blood vessels nearest the heart, leaving the heart, are elastic arteries. So as you can see there, their job is to conduct. So again, basically they're going to have a really thick layer of smooth muscle around them, and a really thick layer of elastic fibers, and so, or two thick layers of elastic fibers there. And so that's going to allow them to stretch and recoil and to propel blood along the arterial side. We go from that conducting system to the muscular arteries, and those are, as you can see there, the distributing arteries. So those are going to be responsible for delivering blood to our organs, and those can be pretty large arteries or relatively small. So they can be arteries like your femoral artery, which is in your groin area, which is pretty big. It's not quite the size of your pinky, but it's pretty close. And that is the primary blood supply for your leg. And so obviously that's a pretty big blood vessel. So most of the named arteries, like your femoral artery, your brachial artery, which is right behind your biceps on the medial aspect of your arm, those are or fall into the category of being muscular arteries. So those distribute into smaller arteries, and then they distribute into the arterioles, and then eventually we get to the capillaries. So we move from those muscular arteries to the arterioles. So the arterioles, as you can see on this diagram, so moving from a muscular artery here into the arteriole, they have a little bit different arrangement of their smooth muscle. So they have a layer or a set of ringed smooth muscle around them, if you will. And so that smooth muscle, when it contracts, again, is going to cause vasoconstriction and close the blood vessel off. So the arterioles serve a really important function in directing blood flow, either away from or to a tissue. And yeah, that's their primary job. So where it says resistance, by that smooth muscle contracting, again, that's going to cause vasoconstriction. You're going to narrow the vessel diameter, and that increases resistance to blood flow. So that's why the resistance phrasing is on there. So here's a depiction of that. So you've got your, see the terminal arteriole there. So you've got blood flowing this way, and then you have these things. So these are those rings of smooth muscles, these precapillary sphincters. And so at this point, they're all relaxed. And so what we're getting is blood flow going this way, blood flow going this way. So all that smooth muscle is relaxed. But let's say this tissue is at rest, so it doesn't need a lot of oxygen. So one of the stats I haven't thrown at you yet, but I stole it from another physiology book, is that, so hopefully you'll remember that on average we have about 5 liters of blood, right? And we turn over those 5 liters once every minute. But if we dilated, if we opened up all the blood vessels in the body, so if you opened up all the blood vessels in the skin, in your skeletal muscles, in the abdomen, trying to think of any other places you might open them. Those are the primary places. If you opened all those up, your system can hold about 20 liters of blood, but we've only got 5. And so what that means then is that some blood vessels have to be contracted all the time. And basically, effectively, what we do is we alternate. So in the calf, for example, when you're at rest, if you're just hanging out, only 1 out of every 30 or 40 blood vessels will be open, and then we just rotate which one is open. That way, the tissue that is largely inactive doesn't need a lot of oxygen, but needs some. So open up a blood vessel, get that tissue some oxygen, and then once it's good, we'll close that precapillary sphincter and then open up another one so that other muscle cells can get their blood flow. Again, if they're not active, they don't need a whole lot of oxygen. And so what you're seeing, what you'll see in a future graphic that I'll show you in a minute, is what we can do is we can actually close these precapillary sphincters, and then what it'll do is that blood flow won't go through this capillary bed anymore, and it'll actually just continue straight on to the venous side. So those arterioles then are going to be really important in that direction of blood flow. If a tissue doesn't need a whole lot of oxygen because it's resting, at any point we can direct blood flow away from it and toward tissues that need more blood flow at the moment. In terms of capillaries, so remember those are our little microscopic exchange vessels. And so you can see this type of capillary here is called a continuous capillary. And it's continuous because the endothelial cells here are continuous with each other, as opposed to the fenestrated capillary has a bunch of little Swiss cheese-like holes in it, and then the sinusoid capillary, there's gaps between the cells. So the continuous capillary, the cells are solid, there's no holes in the cells themselves, and they are continuous with each other. And so by cells, again, I mean the endothelial cells. And so what you've got here in our continuous capillary, and this is the type of capillary that we're going to talk about the most because these are found in skeletal muscle, which is of course our interest in this class, or one of our primary interests, as well as the skin. So these endothelial cells have tight junctions between them. Hopefully you remember those from chapter 3. And those keep things from passing between the endothelial cells. Now we can loosen them under certain circumstances. We can loosen those junctions. For example, we talked about inflammation and basically like that allowing white blood cells to pass between the endothelial cells. So we can loosen those junctions if we need to. But again, under normal circumstances, you got some good tight junctions here. And so you've got this continuous layer of cells. So again, one of the key things about capillaries is that they are basically one cell layer thick. You can see there is a basement membrane here, and then there are these little pericytes. But essentially, it's a pretty thin layer or set of layers that oxygen has to diffuse through. And so that's where we're going to drop off oxygen and pick up carbon dioxide, is in these capillaries. And again, even in some of the smallest ones won't have this basement membrane. So one of the other things I have on there about them is that they're responsive to training. So again, these continuous capillaries are the ones that we find in skeletal muscle cells. So in response to endurance training in particular, or even high volume resistance training, you can add additional capillaries, or you don't add them, but you synthesize, you create new capillaries around trained muscle cells. So after an endurance training program, for example, a slow twitch fiber may have started the program with 3 capillaries around it. By the end of the program, you may have 6 or 7. And so the idea there is that more capillaries allows for more surface area for oxygen to diffuse into the working muscle cell. So more capillaries equals better oxygen delivery. So they are one of the adaptable components of training. So I mentioned the 3 types. Continuous here, mentioned why it's continuous. The fenestrated ones, as I touched on briefly, the endothelial cells have little holes in them, and so they look like Swiss cheese. So this is a fenestrated capillary, and we see those where there's filtration going on. So you see those in the kidneys, because we're dropping off water and then reabsorbing the vast majority of it. We're allowing sodium, potassium to pass, and then we're reabsorbing the vast majority of it. And so those holes then in those endothelial cells allow large molecules and fluids to pass relatively easily. So we see these fenestrated capillaries where there's a lot of filtration, like in the kidneys, or absorption, like in the small intestine. And then our sinusoidal capillaries. So we're not really going to talk about these much because the places where they're located, as you can see, the liver, the bone marrow, and the spleen, we touched on the bone marrow some insofar as that's the site where we generate new blood cells, both red cells and white cells. We talked about them, or I hinted at them a little bit when I talked about the formation of platelets. And we won't really honestly talk about it much with the liver. So not going to touch on these much, but the thing to know about sinusoidal capillaries is that they have fairly large holes in them, right? So you don't have that continuous endothelium. There's big gaps between the endothelial cells. There are far fewer numbers of tight junctions, and then the fenestrations are much less like Swiss cheese and more like big holes in the cell. And so again, you're going to allow larger objects to pass through them, including, as you can see there, some of the macrophages will extend their little processes through these so that they can phagocytize, so that they can attack anything that they need to, for example in the spleen, that helps them with their cleanup function, or where they attack any sort of invading pathogen. All right, so then on the venous side, so veins, as mentioned earlier, carry blood back toward the heart, and in the systemic circulation, carry deoxygenated blood. So the structure of veins is similar to arteries. There's a couple of key differences between them. So the first is that they have a larger lumen, so it's bigger. The second is that the tunica media here you can see is much thinner than what we see on the arterial side. And that's because on the venous side, the veins are a low pressure system, and we'll talk about why that matters in a minute. But to see evidence that the veins are a low pressure system, what you can do, and I'm doing it now, but of course you can't see me, but what you can do is find a vein like on the back of your hand, is usually kind of one of the easiest spots, or even on your forearm. Basically, you'll start proximal, put your finger over it, start proximal, and work distally, and you can kind of wring the blood out of those veins. And then once you release the pressure, you'll watch the blood come back into them. So it's pretty easy to move blood out of veins and then have it come back. That doesn't happen on the arterial side, because the arterial side is a high pressure side. So you can't, run your finger along the radial artery and wring the blood out of it. It's not how it works. It's a higher pressure system than that. So the veins then, low pressure system, they have, again, a thinner tunica media there, but to offset that, they have a larger tunica externa. And so they have a denser network of collagen fibers around them, which enables them to serve as a capacitance vessel. So what that means is that they hold extra blood. Or not extra, but they hold about 2/3 of our blood when we're at rest. So most of our blood is on the venous side at rest. Now that changes during exercise, because we're going to constrict the veins as well as the arteries. But at rest, they're going to hold about 2/3 of our blood. And so effectively then, because they've got a larger lumen, because they've got a thinner muscle layer here, that blood just kind of pools on that venous side. And then that tunica externa, those dense collagen fibers, keep it from bulging out too far. One of the other things that the veins have, and I'll actually click back to this one because there's a picture of them, that the arteries don't, is that veins have valves. So think back to what we talked about in the heart. You had AV valves between the atria and the ventricles, and then you had semilunar valves between the aorta and the left ventricle, and then pulmonary semilunar valve between the right ventricle and the pulmonary arteries. And so remember that valves then prevent backflow of blood. And so they serve the same function here in the veins. So you have valves in the veins of your arms and legs. You have a few in the abdominal cavity, but not very many. And so what they do is they prevent that backflow of blood, and thereby what's referred to as venous pooling, which is basically too much blood collecting on the venous side. So what ends up happening then is, because obviously most of us are, our legs are kind of hanging down all day, or our arms are kind of down by our sides. And so as we'll stick with the arterial system, pushes the blood through, the blood will move up, so you'll have a little increase in pressure, and then the blood will move up past this valve, and then you'll get some relaxation down here. That would tend to allow gravity to pull the blood back down, toward the fingers if your arms are by your side, or toward the feet if your legs are hanging down. And instead, that blood's going to stop at this valve. And then the next time we get an increase in pressure, we'll push it up past the next valve, and then it'll get stuck there, and then eventually till we get back to the heart. So going back to the inferior or superior vena cava. So veins have valves. We talked about the capacitance role. So what this little graphic is, so that is at rest, that veins hold about 60%, so give or take 2/3 of the blood at rest. Varicose veins over here are when you get a defective valve. And so when you get a defective valve, so you can see the normal valve here that's doing what it's supposed to be doing, it is going to stop that backflow. But then varicose veins, it doesn't stop the backflow, and so we start to get blood pooling. You start to get that blood pushing out against that tunica externa. The externa becomes distended, and so then you start to see these superficial veins bulge out, and so those are your varicose veins. So that typically happens in surface veins because there's less tissue on top of them. It's basically just a few layers of fascia, of skin, of subcutaneous fat, and so there's not a lot of pressure on them. There's not a lot reinforcing them, and so because of that, those are the ones that tend to have valve issues. You also tend to see varicose veins in people, so it's almost, not always, but it's largely in the lower body, and you see it particularly in people that have to stand all day. So, you know, industrial workers sometimes, if they're working like on the assembly line, or you'll see them in like hairdressers, anybody that has to, or chefs, anybody that has to stand all day, because of that strong pull of gravity, you know, all day long, tends to wear out those valves a little faster. In terms of venous pooling and the cool down, so venous pooling, again, is basically just too much blood pooling on the venous side. So one of the things that pushes blood back to the heart, and I have a whole nother slide about this in a minute, but I couldn't figure out how to order it. But one of the things that pushes blood back to the heart is something called the muscle pump. So effectively, every time you move, so like if this guy were to take a step and his calf contracts, that would push blood past this valve, and then if he contracts his calf again, push it past the next valve, right? And so that pushes blood back toward the heart. It's called the muscle pump. Well, if we stand for prolonged periods of time without moving, we don't push as much blood back to the heart, and so that reduces what's called venous return. And venous return is blood coming back to the heart. Well, if you're not getting as much blood back to the heart, then you're not getting as much blood leaving the heart. And so if not as much blood is leaving the heart, you're not able to deliver oxygen as effectively as you'd like to be, and that includes not only to, you know, skeletal muscles, to your kidneys, to your liver, etc., but that also includes a reduction in blood flow to the brain because you have a reduction in cardiac output. And so that can cause a temporary loss of consciousness, which is my little picture here. So that's why if you've ever been to any sort of a thing like a wedding or like military parades, those kinds of things, and people are told not to stand there with their knees locked, that's why they're told that. I remember a long time ago now when my wife and I got married, that one of the bridesmaids was just like adamant. That was like her one piece of advice, was like walking around telling everybody, like, do not stand with your knees locked because one of you is going to pass out. Like, we don't need to see that. We don't need that on video. And so so the advice was sound. You don't want to stand there with your knees locked, but effectively what happens is, so if you're standing there with your knees quote unquote locked, what that means is that your knees are probably slightly hyperextended. And so you are, by hyperextending your knees a little bit, you are relying on the posterior capsule and the PCL of the knee to hold you up. So basically you've transferred the effort, if you will, to hold you up to the connective tissue rather than to the muscles. So you're getting less muscle contraction, means you're getting less muscle pump pushing blood back to the heart, means you get more venous pooling, which means you get less blood to the brain, so then people pass out. Now if you then unlock your knees, what you're doing is you're engaging the quads, you're engaging the hamstrings and the calf musculature, not much, but a little bit, and so by doing that, that's enough to facilitate normal venous return, and the brain gets all the blood that it needs, all the oxygen that it needs, and so you stay conscious. All right, so blood pressure. So a few things here. So obviously blood flows from high to low pressure, right? Blood's under a lot of pressure when it leaves the left ventricle. The left ventricle is pretty big and strong and ejects blood out pretty hard. And so it flows from that area of really high pressure, just leaving the left ventricle, out to an area of low pressure in the tissues. And you can see the definition of blood pressure there. So the force per unit area exerted on a vessel wall by the contained blood. And so it's expressed as millimeters of mercury. Sometimes there's a slash, sometimes there's a space. And so as mentioned before, normal blood pressure is expressed as, well, yeah, there you go. So 120 millimeters of mercury is your average, your normal blood pressure. So remember that the two components there, the two numbers, 120 is the systolic pressure, 80 is the diastolic pressure. And so further, hopefully you'll remember that systole is when the chambers of the heart are contracting. Specifically when we're measuring blood pressure, we're measuring the left ventricle, so we're measuring ventricular contraction. So the top number then, systole, is effectively a measure of how hard the left ventricle is contracting, and then diastole is resistance to flow, which you can see down there. And so what that measures then, so when we say 120 millimeters of mercury, what that is equivalent to is the pressure exerted by a column of mercury 120 millimeters high. which for those of you like myself, not good with the metric system, that's 4.72 inches. So the weight of a column of mercury that's just shy of 5 inches high, that's how much force the left ventricle exerts against the aorta when it's contracting at rest. And then that number can go much, much higher. So during exercise, like during endurance exercise, running, cycling, those kinds of cyclic activities, swimming, those kinds of activities where you get muscle contraction and then subsequent relaxation and you just cycle them over and over again. Systolic pressure will get, oftentimes over 200. During really intense muscle contractions, like during max out on deadlift or leg press or squats, those kinds of things, there have been some instances where systolic pressure has been measured at over 400 millimeters of mercury, which is mind-blowingly high. So that's a really high number. And then diastolic pressure, again, is normally like 80. So during exercise, it's typically, during endurance exercise, it stays pretty close to there. So it stays around 80. It may jump up a little bit, maybe like 100. But during resistance training, it actually goes up quite a bit more. So in the studies where they found during maximal leg presses where some elite powerlifters were able to get their systolic pressure over 400, they were able to get their diastolic pressure into the high threes, like 380-ish. So lots of resistance to blood flow. All right. So as mentioned there, so resistance is opposition to flow, and it's a measure of the amount of friction that blood encounters as it passes through the vessels. So there's three factors that play into, or that play a role in increasing or decreasing the resistance to blood flow. The first is the viscosity of the blood itself. So remember that viscosity is essentially a measure of the thickness of blood, like how syrupy is it, how thick is it, right? So increased viscosity means the blood is thicker. Decreased viscosity means that the blood is thinner, so it's more water-like. So if we say that something is less viscous, it's a thinner fluid, it's more water-like. So the more viscous blood is, the more opposition it has to flow. The harder it is for the heart to pump it is kind of the easy way to look at it. So blood viscosity stays relatively constant. It does change some, for example, with dehydration. So in a number of exercise studies, they've looked at essentially the workload of the heart with dehydration. And so as you lose plasma volume, the blood gets thicker, right? It gets more viscous, and so it gets increasingly difficult for the heart to pump it. And so that's kind of one of the reasons that there's the advice, like, oh, you need to stay hydrated during exercise, is that you want to maintain your relatively normal blood viscosity, or even maybe make it a little bit thinner. And so by doing that, you take some of the workload off of the heart. You're able to supply oxygen easier. Other than viscosity, another thing that impedes or slows down blood flow, resists blood flow, is the length of the vessel, which is not something that we can change. So your blood vessels are a set length. It's dependent upon how tall you are. So, but from a practical standpoint, I guess, or an impractical standpoint in this case, longer vessels slow blood flow down. Shorter vessels, there's less resistance to flow. But again, that's not something we can change. But what we can change is vessel diameter. So the larger the diameter of the vessel, the less resistance to flow there is. The smaller the diameter of a vessel, the more resistance to flow there is. And so one of the things I mentioned earlier is that we can increase or decrease the diameter of a blood vessel within limits, of course. And so by decreasing the diameter of a blood vessel, we effectively shut off blood flow distal to that site. And so what we've done in the context of this part of the discussion is we've increased the resistance. We've increased the opposition to blood flow there. So blood pressure we talked about a little bit with the heart, and we talked about a second ago. And again, so remember the top number, the 120 in your typical blood pressure. The top number is a measure of how hard the left ventricle is working. The bottom number, the diastolic pressure, is a measure of resistance to flow. So a second ago I said that in elite powerlifters doing maximal leg presses, we've seen, or not we, me included, but researchers have seen that blood pressure can reach numbers, 400 over 3 something, right? And so what's happening there is During that maximal leg press, the muscles are contracting really hard for several seconds at a time. Probably takes, somewhere in the neighborhood of 3 to 5 seconds to complete that lift. And so in doing that, when the muscles are contracting, obviously they're shortening, right? And so when they shorten, the cross-sectional area of the muscle increases temporarily, so they have a temporary increase in their diameter. But what that does is that presses on the nearby blood vessels. So in pressing on the nearby arteries, that's going to induce vasoconstriction, and so then that is going to impede blood flow. So when we have sustained muscle contractions, like we do during maximal lifts in particular, that is going to narrow blood vessels in the lower body, in that case of doing leg presses, and by doing that you dramatically increase resistance to blood flow because you have decreased the diameter of those vessels. And so because resistance has increased so much, now we have to increase our systolic pressure more than that if we want to get blood past that point. So the systolic pressure has to stay higher to overcome that resistance to flow. So that's kind of I think the best way to think about those things. In the case of endurance training, so I mentioned that the diastolic pressure typically stays about the same. And so what happens there on the diastolic side of things is that during endurance exercise, we'll actually open up more blood vessels. And so you get eventually more systemic vasodilation. And so with that, you get more vessels open, greater surface area for oxygen to diffuse, and so you get then reduction in resistance to flow. You've effectively increased the diameter of the vessels by adding more vessels. So you decrease resistance to flow, and so systolic pressure is going to increase some because you're going to get, with that repetitive and cyclical muscle contraction, you're getting more blood flow back to the heart, which means increased venous return. And so then with that increased venous return, just that increase in blood volume increases pressure. And so that's going to drive that systolic pressure up. So systolic pressure goes up because of an increase in venous return. Diastolic pressure stays about the same, may even go down because of dilation of blood vessels in the working musculature and in the skin, because usually you're kind of hot with endurance exercise. So other things on there. So obviously blood flow is proportional to the pressure. So the harder you push, the more blood flow you get, and inversely proportional to the resistance. So the more resistance you have, the less blood flow you get, right? So we talked about systolic pressure, diastolic pressure. MAP stands for mean arterial pressure. So remember that a mean is an average. And so mean arterial pressure is not a straight up average of the two numbers. So if we've got our systolic pressure at 120, diastolic pressure at 80, you would think your mean arterial pressure would be 100, right? It's the midpoint between the two. It's the average of the two. But what ends up happening is your mean arterial pressure is actually a little bit lower. It's more like 93 because in terms of the phases of the heart, so diastole is actually a little bit longer than systole. And so because of that, the mean arterial pressure is a little bit lower than 100, like I said, about 93 rather than being 100. So mean arterial pressure is kind of a way to get an idea of the average pressure on the aorta or on those big elastic arteries, because they're going to get a really big pressure whenever the left ventricle contracts and then a big drop off. And so it's a way of conceptualizing sort of that average pressure that they endure. And as you can see, as we move from the aorta into the arteries and eventually into the arterioles and the capillaries, you're going to get a big drop off in that mean arterial pressure. So the pressure constantly drops as we move along the blood vessels until we get down here into the capillaries, the purple zone, and we only have, somewhere around 25, give or take, millimeters of mercury worth of pressure in the capillaries. That's good. That low pressure is actually what we want in the capillaries because that facilitates the offloading of oxygen. So it allows the blood flow to slow down a little bit, and as that blood flow slows down, we get the chance to offload that oxygen and pick up carbon dioxide. If the blood was under higher pressure, that is going to speed up blood flow, and then that does not facilitate offloading of oxygen or onloading of carbon dioxide. And then the other thing is that increased pressure would actually push more fluid, more plasma into the tissues, so it could then lead to swelling as well. And so then that could be problematic. So we actually want this low pressure here. And then you see on the venous side, the pressure just keeps on dropping until we get over here to the vena cava. So again, the veins are a low pressure side. Basically, the left ventricle of the heart contracts. We get the expansion of the arteries and their recoil, which is your pulse, until we drop off oxygen at the capillary side. And then on the venous side, there's really, really low pressure. That pushing from the left ventricle, that wave, has essentially kind of played itself out by the time we get onto the venous side. So because there's such low pressure on the venous side, then we have to do different things to facilitate blood flow back to the heart. So the first one that I mentioned there is the muscle pump. So if you are, to use the example from earlier, if you're standing for a long period of time, but your knees are unlocked, they're slightly flexed, you're engaging the hamstring muscles, the quads, the calves, etc. And so in doing that low-level muscle contraction, again, as those muscles contract, they're going to push on this blood vessel, and they're going to push blood past this next valve, and then when those muscles relax, that blood flow would tend to go backwards, but it can't because of that valve. So that's the muscle pump. As the muscles contract and relax, that compresses and relaxes around the veins, and so that pushes blood back toward the heart. And again, venous return is blood flow back to the heart. The respiratory pump, so just as we breathe, that increases and decreases pressure both inside of the thoracic and abdominal cavities, and so that serves a similar function. So by that repetitive increase and decrease in pressure, that helps push blood back up toward the heart. And then sympathetic venoconstriction. So remember the sympathetic side, that's our fight or flight. And so again, on both the arterial side and on the venous side, that is going to cause constriction of smooth muscle, so of that tunica media around those blood vessels. And so when we do that around the veins, when we close their lumens, when we decrease their diameter, that pushes blood flow back to the heart. So during exercise, or if you're frightened, either way, both of those are fight or flight, sympathetic type responses, you're going to get that sympathetic venoconstriction, and by closing down the diameter of the veins, that's going to push more blood back to the heart. So in terms of blood pressure regulation, there's a few different ways to do it, both short-term and long-term. So in the short term, oops, dropped my mic, sorry. There we go, got that back, hold on a sec. Put that back through my shirt. There we go, okay, perfect. So in the short term, we can regulate blood pressure through neural control, so through the brain. So as you can see here, we maintain our mean arterial pressure on a minute-by-minute basis, so it constantly needs adjustment, especially if we are changing what it is that we're doing. So we can use neural controls primarily to direct blood distribution. So I've mentioned a couple times the fight or flight response, which causes systemic vasoconstriction. But the other side of things is the rest and digest response. And so if you're like me, I'm at the moment sitting in front of my computer, not really doing much other than talking. And so my skeletal muscles, like in my calves and in my legs, they don't really need very much blood flow at the moment because they're not very active. And so we'll direct blood flow away from them, and we'll actually direct it toward the intestines, toward the stomach, toward the kidneys, the liver. And so that the neural controls play a really important role in that. And further, they are influenced by baroreceptors, which baroreceptors are a special type of stretch receptor in the aorta, and you can see they're in the carotid sinuses. And so they are kind of like the governor. If you've ever driven like a U-Haul truck where it won't let you go over 60, and if you try to go over 60, it kind of shuts it down. Baroreceptors serve a similar function. If your blood pressure gets too high, they will then send an inhibitory signal, causing a decrease in output from the sympathetic nervous system. So basically they act to cause you to decrease heart rate and decrease blood pressure. So remember, actually thinking about what we've talked about recently, remember the sympathetic side, it is connected to the SA node and the AV node as well as the left ventricle. So that if we have sympathetic activation, we can increase heart rate, but we can also increase blood pressure. Well, if we increase blood pressure too much, again, we're going to activate these baroreceptors, which act as the governor, and so they decrease that sympathetic outflow, which then acts to reduce heart rate, but also reduce blood pressure, which is actually their main goal, is to reduce blood pressure. And then chemoreceptors are primarily responsive to the pressure of carbon dioxide in the blood. And so if carbon dioxide starts to accumulate in the blood, that's going to speed up heart rate, and then that's also going to cause a general vasoconstriction. And then if we get a decrease in pH, meaning the blood is getting acidic, and it's probably getting acidic because the muscles are contracting and generating some lactate or lactic acid, then that'll also increase heart rate. So this particular diagram is if blood pressure gets too high. So you can see we've increased blood pressure, so we have stimulated these baroreceptors, which are then going to interact with the brain, and so that is going to decrease our sympathetic outflow, so that'll decrease heart rate, decrease contractility, and hopefully decrease carbon dioxide. And so that's also, when we decrease sympathetic outflow, that is going to allow for vasodilation, which then that decreased resistance of vasodilation allows for, so effectively by allowing for vasodilation, you bring down the diastolic blood pressure, which then, because there's less resistance to flow, the systolic blood pressure can come down. And then this one's the other side of things. So this first diagram is when blood pressure gets too high, short-term changes that can happen to bring it back down. So let's say, you are outside and a car backfires and you get scared briefly. You're going to get a quick spike in blood pressure, and then you're like, oh wait, no, it's just car backfiring, everything's cool. Here's how you're going to bring it back down. So this is the loop to bring your blood pressure back down, and then this is to go the other way. So blood pressure drops, we're not getting any stretch there in the baroreceptors, and so then we can activate the sympathetic side. So then that's going to increase heart rate, increase blood pressure, and then we're going to cause sympathetic vasoconstriction. So then that increases resistance of flow, that increases our blood pressure. Other short-term controls, so we've got hormonal controls. So we'll talk about the endocrine system separately, but there are some endocrine responses to, or I guess endocrine controls to help us maintain blood pressure. So the first hormonal controls are epinephrine, norepinephrine, and those two are neurohormones. They serve both as neurotransmitters and hormones. And so what they do is, with the onset of exercise, or again, with that fight or flight response, so whether it's you're scared or the onset of exercise, and or stressed, right, because that falls under the fight or flight response, any of those things, we release epinephrine, norepinephrine. That's going to cause systemic vasoconstriction. And it seems like, well, we're about to exercise, you'd want to open blood vessels up. But we actually do the opposite. We actually close blood vessels down throughout the system, and it's epinephrine and norepinephrine that are primarily responsible for doing that. Angiotensin comes about because of the kidneys. So the kidneys, in response to low blood pressure or low blood volume, the kidneys are going to release something called renin. And once that's released, the end result is the creation of this other signaling molecule called angiotensin 2. And so what it does is to stimulate vasoconstriction to try to get blood pressure back up. But in addition to that, it also stimulates the release of two other hormones, antidiuretic hormone that you can see down here. And so antidiuretic hormone has an effect back on the kidneys, where it causes the kidneys to, or vessels in the kidneys to, tubules more specifically in the kidneys, to constrict. And so by doing that, we hang on to more of the water that's flowing through the kidneys to try to keep our blood volume up. And then aldosterone, what that's going to do is allow us to, or stimulate the kidneys to hang on to more sodium. When we hang on to sodium, that's going to pull water with it, as we've discussed before. So angiotensin then, I guess the thing to know about it, it causes the release of antidiuretic hormone, makes us hang on to water, also causes the release of aldosterone, makes us hang on to sodium. Both of those things increase plasma volume, and by increasing plasma volume, we increase total blood volume, that increases blood pressure. So that's how angiotensin 2 does it. The atrial, even I'm struggling with this one, natriuretic peptide, or ANP, we'll stick with ANP. I wish they'd ordered this table a little bit differently, because you can see that all the other ones we talked about cause increased blood pressure, increase. And so ANP does the opposite. It actually decreases blood pressure. So I wish they'd stuck it at the bottom, but they didn't. So ANP is produced by the atria of the heart, and it's produced if blood volume and blood pressure get too high, it's released. And so it acts to antagonize, acts to do the opposite of aldosterone. So it causes us to release more sodium or to excrete more sodium through the kidneys. It also causes us to excrete more water through the kidneys. And so by doing both of those things, it does the opposite of what angiotensin does, and causes us to lose blood volume. And so then that's going to decrease blood pressure. Long term, so if your blood pressure gets too high, so the direct mechanism is as blood pressure increases, the rate of blood flow increases, and so the flow of blood through the kidney tubules speeds up, and when that happens, we're going to lose more fluid as urine. Now, during exercise, because obviously you're going to increase blood flow quite a bit during exercise, that is offset by antidiuretic hormone and aldosterone. But if blood pressure is just up because you're stressed, then that can cause increased fluid losses because of that increased rate of blood flow, so increased pulse and increased blood pressure. So that's the direct mechanism. The indirect mechanism we kind of already talked about. So if your blood pressure drops, again, the kidneys are going to release renin, which then gets converted to, it doesn't itself get converted to, but causes the splitting of angiotensin, and then we make angiotensin 2. And then, as discussed, angiotensin 2 stimulates the release of aldosterone, which causes us to hang on to sodium, stimulates the release of antidiuretic hormone, so we hang on to water. But in addition to that, that mechanism also increases thirst, acts on the hypothalamus in the brain to increase thirst, and then is also a systemic vasoconstrictor. And then so these are a couple little handy charts, I guess, figures would be the appropriate term. A couple handy figures. So there's the direct and indirect mechanisms in picture form. All right, so I mentioned, here's the picture I was going to show you earlier. There's that. So again, those precapillary sphincters can regulate blood flow. So if they are closed, as they are here, so again, the example I used earlier, the stat I used earlier was that at rest, only 1 out of every 30 or 40 blood vessels in the calf is open. And so this would be at rest. Your calf musculature doesn't need a whole lot of blood flow, and so we're just directing blood right past it. And then, here and there for a few seconds, so we'll dilate this one. We'll let these muscle cells that would be down here get some blood flow, and we'll close this, we'll open the next one. And that way, the muscle cells get enough blood flow that they're able to supply oxygen to carry out basic maintenance activities, but they don't need very much. Then during exercise, we get the opposite. So we're going to open all of them up so that we can deliver lots of oxygen to that tissue. So one of the things I mentioned earlier is that the hormones that are released during exercise, so epinephrine, norepinephrine, are going to cause systemic vasoconstriction. So we basically close blood vessels down throughout the body when exercise starts. And so that's going to close off blood flow to the intestines, to the kidneys, to the liver, but also initially to skeletal muscle. But when we start exercising, you have some neural control, so some feed-forward mechanism that's going to open up these precapillary sphincters toward the working musculature. But in addition to that, the muscles that are, again, not pictured, but the muscle cells that would be here in this capillary bed are going to generate byproducts of energy production. So that's going to include things like carbon dioxide. And in addition to that, you're also going to have the production of, or you're going to get a decrease in pH, so the blood around them gets increasingly acidic. You're also going to have an increase in temperature. And so all of those things then, the increase in temperature, a decrease in pH, increase in carbon dioxide pressure, are going to stimulate then the opening of any of these precapillary sphincters that weren't already open because of neural control. So basically what happens is we get this systemic vasoconstriction. We close off blood flow pretty much everywhere, other than obviously like the brain and the heart. But we close off blood flow pretty much everywhere, and then as the muscles are working, the byproducts of muscle contraction stimulate the opening of the relevant blood vessels or the nearby blood vessels so that those particular working muscles or muscle cells can get the blood flow that they need. The other thing that opens up blood vessels, or one of the other things, is the increase in blood pressure itself. That increase in pressure on the arterial side causes the release of nitric oxide. And so nitric oxide is produced by those endothelial cells, and it causes the smooth muscle layer in the tunica media to relax. So nitric oxide is a fairly potent vasodilator, causes that smooth muscle relaxation and opens blood vessels up. So that, like I said, the increase in blood pressure with exercise can stimulate that nitric oxide release and reflexive relaxation of the underlying smooth muscle. And then the last thing, so what we get, and this term is, or this, not term, but this phenomenon, we'll go with that, is oftentimes referred to as blood shunting. And so what blood shunting is it's direction of blood flow to where it's needed. And so what you can see here on the left side, so this is our blood flow at rest, and this person has a pretty high blood volume, so they have 5,800 mLs, so that's 5.8 liters. So at rest, you get almost a liter per minute going to the brain, quarter liter going to the heart, not very much going to skeletal muscles, some going to the skin. The kidneys are getting quite a bit, so the kidneys are getting more than a liter. Your abdominal organs, your stomach, your intestines, your liver are getting more than a liter as well. So during rest and digest, when you're just sitting in class, this is kind of your blood flow distribution. So you're filtering your blood, you are absorbing the things that you ate. The liver is also has some level of filtration responsibility, but it's doing other things. It's making new proteins, making glucose if it needs to, and so it needs blood flow to do that. And then if we shift to exercise, so now we've increased our cardiac output. So remember that, heart rate, stroke volume. We've increased our cardiac output almost 3 times to 17.5 liters per minute. And so what has happened then is during exercise, again, we need to direct blood flow to the tissues that need it most. We have to prioritize. Now, the brain is always number one, so the brain gets its blood flow no matter what. So it's still getting the 3/4 of a liter that it needs. Now the heart is working harder, so we have had to triple blood flow to the heart, but you can see the skeletal muscles, we've gone from 1.2 liters to 12.5. So we've increased the amount of blood flow to the working muscles 10 times. And we've increased blood flow to the skin to help us dissipate the heat. So we're gonna increase blood flow to the skin so we can give up plasma volume to evaporate away and help maintain core temperature. But we've done all of those things at the expense of the kidneys, which before, again, we're getting more than a liter. We've cut their blood flow in half. The abdomen was getting almost 1.5 liters. We've cut its blood flow by more than half. And then anywhere else, we've also decreased their blood flow. So that's, again, blood shunting. So during exercise, you direct blood flow away from the abdomen, so away from the kidneys, the liver, the stomach, the intestines, toward the working muscles, toward the skin, and then also the heart gets more blood flow so that it can compensate for its increased workload. So there you go. All right, so that's the end of blood vessels. So we finished up this chapter. There is a discussion board for this week, so make sure you wrap that up or do that by the end of the week. And then next week, we're going to move on to a related system, which is the lymphatic system. So it's going to be responsible for returning fluids back into the venous side. So we'll see you next week.